Welcome back to the NRG Oncology Podcast to kick off the July 2026 semi-annual meeting here in Denver. It turns out that our semi-annual meeting coincides with the annual Glioblastoma Awareness Day, which occurs on the third Wednesday of July every year. Today, we're bringing you a podcast on glioblastoma with Dr. Huang, who is leading the recently activated NRG Oncology CC017, looking at temporally modulated pulsed radiotherapy, or TMPRT for glioblastoma. I've known Dr. Huang for many years from my time at Washington University in St. Louis, where I was once his resident and then later his colleague, and where he is presently a professor of radiation oncology and chief of the CNS Radiation Oncology Service.
And believe it or not, I've known Dr. Huang even longer than Lauren, since we both participated in the 2014 ASCO AACR Methods in Clinical Research Workshop, which I think was previously known as the Vail course, but it's somewhere like San Diego now. Dr. Huang, Lauren and I know you pretty well, but for those of us out there who might not know you, what makes you so passionate about treating brain tumors and glioblastoma in particular?
Hi, Stephen and Lauren. It's great to see you guys both, and thank you for the opportunity to talk about NRG017 today on your podcast. Since joining WashU after residency about 14 years ago, I have subspecialized in treating patients with brain tumors. When I initially went into the field of radiation oncology, I just want to be a doctor who treats cancer patients. I later on wanted to subspecialize because I want to focus and try to develop better treatments for cancer. After residency, there was opportunity at WashU to focus on brain tumors. So here I am, a CNS radiation oncologist. There's a joke that glioblastoma gives cancer a bad name. Glioblastoma is the most common malignant brain tumors and one of the most lethal cancers. For CNS radiation oncologists, it's like my arch enemy, like Joker to Batman or Lex Luthor to Superman. Furthermore, both the glioblastoma and the treatment also have enormous impact on our neurocognition. I would argue our neurocognition is what makes us human. So this terrible disease not only take our lives, but also rob us our humanness, our thinking, our memory. The reason I design clinical trials and take workshops like the Vail course is to try to find novel therapies that can not only improve treatment of glioblastoma, but also reduce neurocognitive decline from the treatment and the disease.
I really like you're referring to yourself indirectly, I think, as Batman and Superman. I'm not sure which one I want to use for the rest of this podcast recording, but I like them both.
You know, people say that I sound like Darth Vader.
Not all of us can have your base, Stephen. So that being said, in CC017, as you pointed out, Jay, we are looking at the worst of the worst. Even in the realm of glioblastoma, there are more favorable outcomes in patients who, for instance, have MGMT methylated tumors and in tumors with isocitrate dehydrogenase or IDH1 mutations. But patients eligible for CC017 must have glioblastoma without MGMT methylation or IDH1 mutation. What makes these MGMT unmethylated IDH wild-type glioblastomas so bad? And in addition to radiation, can you speak a little bit about the role other multidisciplinary treatments involved in the management of these patients have, like surgery, chemotherapy, and tumor treating fields?
Yes, Lauren, you're absolutely right. There are four things that has been proven to be beneficial and to improve survival for patients, and they are surgery, radiation therapy, temozolomide, and this device called tumor treating field. As a radiation oncologist, I believe radiation oncology really is the most important of all of them. MGMT unmethylated glioblastoma are not very sensitive to chemotherapy, such as temozolomide. So radiation therapy really have to do most of the heavy lifting after surgery. For those patients with more sensitive tumors, surgery and tumor treating field still play a very important role, and they're part of standard treatment for CC017. One of the major reasons we want to focus on this group is because their outcome is worse. We actually need less number of patients to show an improvement. There are also limited studies looking at this worst of the worst group, and therefore there's a greater unmet medical need. That's another reason we want to focus on this group of patients in this study.
As Lauren mentioned, CC017 is comparing standard radiotherapy with something called temporally modulated pulsed radiotherapy, or TMPRT, for glioblastoma. Can you explain briefly to our audience what TMPRT is and why we think it might work better than standard radiation for glioblastoma?
For standard radiation therapy, you can imagine the daily treatments delivered in a single pulse, a single fraction, and usually it's delivered in maybe less than a minute. However, with the TMPRT, or pulse radiation therapy, it's delivered in smaller pulses with a time interval break. So imagine you have a cake. You can eat the cake all at once, right? Just put in your mouth, or you can cut into 10 slices and you're just eating 1/10 of a slice, and then wait 3 minutes until you feel hungry again, and then eat another slice, and you basically repeat this process 10 times with 3-minute breaks in between. Experiments using tumor cells and animal models have shown that by delivering this slower kind of pulse, there are 4 advantages. First, the tumor cells are actually more sensitive to this low dose pulse delivery because it doesn't trigger a DNA repair mechanism. Second, this doesn't induce the suppressive immune cells into the tumor. Third, this pulse delivery doesn't damage the normal tissue blood vessels in the brain as much as the standard radiation therapy. Last but not least, there appears to be less damage to the normal neurons in the brain. So when I was a resident at Beaumont Hospital, I worked with 2 well-known radiation biologists in this field by the name Dr. Brian Marple and Dr. George Watson. And I and some of my co-residents were part of this research group that performed some of the seminal work that demonstrate those advantage of this technique. Later, one of my co-residents, Dr. George Dorwolf, who is now a associate professor within Beaumont Hospital, conducted a phase 2 trial at Beaumont Hospital that provided proof of concept for this technique in human patients with glioblastoma. So that study showed that this technique in combination with temozolomide not only improve tumor control as compared to standard delivery, but also minimize neurocognitive decline.
That is honestly a great explanation, and I really love the analogy of really slowly eating a piece of cake. It's kind of silly, but it's great, and I think it really draws a clear picture that's easy to understand. So thank you. As I understand it, the primary goal of CC017 then is to see whether temporally modulated radiation therapy reduces neurocognitive function failure, or NCF failure, in glioblastoma. And neurocognitive function failure sounds, of course, like a really not great thing. How is neurocognitive function failure defined? And other than neurocognitive failure, what else are you looking for as an endpoint in CC017?
This neurocognitive failure is actually defined very similar to prior NRG trials. The definition basically is when you perform neurocognitive testing and your score becomes significantly lower than your baseline test. Like when you do a test a second time, you could just maybe score a little bit lower, and that could just because measurement error. And so there's inherent noise with taking that test the second time. So there's a way to define what is considered significantly worse compared to your baseline test. And that's how you define the neurocognitive failure. The battery of tests consists of 6 neurocognitive tests that can be completed in about 30 minutes. This battery of tests is very well validated, has been used in multiple prior NRG phase 3 trials. And the benefit of using this as the primary endpoint is it's a very objective test. It also measures 2 things. 2 things that can affect neurocognitive function. If the tumor is growing, it's causing a lot of damage, that will cause neurocognitive decline. The other thing is treatment itself can also cause neurotoxicity, and that can contribute to neurocognitive decline. By measuring this endpoint, we can assess potential impact on both. So therefore, this primary endpoint is more sensitive to detect a benefit for the TMPRT. And we hypothesize this technique should help both. In addition to neurocognitive failure, we also want to look at many other metrics. We want to look at survival, tumor control, quality of life, patient-reported cognitions, and frailty. In fact, this is, as far as I know, the first randomized phase 3 study in GBM that prospectively measure frailty. Frailty is not just older age, it's actually more complex than that. And so this is a very unique study where we'll study this objectively and how the treatment and the disease can impact frailty.
These days, when we do radiation for glioblastoma, my patients, for example, might be in and out of their treatment in a matter of minutes with modern volumetric arc therapy. You spoke about this a little earlier. Let's put ourselves in the patient's shoes. How might they experience temporally modulated pulse radiotherapy differently than standard radiation? And do you think that there would be any difference in the side effect profile, potentially different side effects? Can any radiation linear accelerator be set up to deliver this, or do you need special equipment or physics credentialing to do this?
Regarding the delivery time, yeah, this is a common question, common concern. So yes, standard radiation therapy for glioblastoma takes about 10 to 15 minutes in the room. Of that, only probably a couple minutes actually for the actual delivery. For the TMPRT, the treatment time or the treatment in the room is longer. It's probably about 30 to 40 minutes, so 3 times longer. However, this delivery duration is probably not so foreign to most radiation oncologists because our standard radiosurgery for patients with other brain tumors, such as brain metastasis, is about the same duration. And there are also other radiation treatment for other, for example, abdominal disease, such as what Dr. Hankey treats, sometimes can take even longer than that. Hundreds of brain tumor patients actually have been treated with TMPRT in both retrospective and prospective studies. Many of them actually have been led by either study co-chairs for this study or by myself. And in our experience, patients have tolerated this treatment very well. And we have not seen it to be too bothersome for patients. Because you can imagine patients actually don't really have to hold still. They just lay on this treatment table and they can relax. They can actually just take a nap, fall asleep, listen to music. Generally, people have not complained to us about the longer treatment time. For TMPRT, we can use any modern linear accelerator and does not require any special machines. As part of this study, we have developed PowerPoints that's in the NRG CTSU website, as well as a webinar with recordings, as well as paper that's in press that details how to plan the TMPRT. There will be special credentialing through the IROC that's necessary to ensure that TMPRT is delivered correctly for the trial.
I appreciate that call out about the lengthy duration of GI delivery when we're doing things like breath holding. It's very true. And I will say that this is a study that we are opening at our institution. And some of the conversation, of course, has dealt with questions of clinical efficiency and machine time, which is always a fact in any department. But I think it's worth reminding anybody listening that MGMT unmethylated IDH wild type patients are not the majority of patients. And so you can open this study and not necessarily expect that your clinical treatment times are going to triple on your machine or something on the whole. I think that that is hopefully not an obstacle to anybody considering this for our patients. We tolerate time-intensive, resource-intense treatments in other disease settings and scenarios, and like you pointed out, for brain SRS all the time. And so if this is something that may be helpful for patients, then surely it's worth that investment. In one of our recent Energy Oncology podcasts covering the 2025 ASTRO late-breaking abstract session, we had Dr. Manesh Mehta speaking about the results of BN001, which is a brain tumor trial showing a possible survival benefit when using proton therapy for glioblastoma. Given the results of BN001 and that protons can also potentially reduce normal brain exposure, I imagine that protons might also reduce neurocognitive side effects and could dovetail with this technique. Can temporally modulated pulsed radiotherapy be delivered with protons? And if so, is proton therapy allowed on CC017?
Yeah, Lauren, before I address the second question, let me just kind of go back to your first question or your comment. I totally agree with you, and I think you make excellent points. Obviously, longer duration is a limitation and I think potential obstacle for this technique. However, we have been treated other patients with longer time, and then if this study shows this is beneficial, I think it will offer meaningful benefit to our patients. As you said, right, this is really just the worst of the worst, and it's relatively rare disease as compared to more common cancers. Even for a busy clinic, you're not going to be treating MGMT, unmethylated GBM, basically every day. And also, since this is a randomized study, only half the people will only get randomized to the pulse RT. So I do think it's quite feasible in many clinics. Furthermore, we also had other investigators say, right, you can kind of select which machine to put patients on. You can certainly select a machine that's less busy or maybe even a satellite that's less busy to treat those patients.
Yeah, I want to add something real quick. I think people forget this would not be the first time we have introduced a technique with radiation that would be some length in duration. If we think back just maybe 20 years ago, RTOG 0236, stereotactic body radiotherapy for early stage non-small cell, Bob Timmerman's landmark study published in JAMA in 2010. Those treatments were on the order of 45 minutes to an hour because it was non-coplanar beams all being shot from different directions with stereotactic technique that was much less advanced. And so there's a precedent within RTOG and NRG oncology to introduce new treatments that may perhaps take longer, but showing that it can be done in a cooperative group setting in the community.
Yeah, that's an excellent point. I totally agree. Those kind of historical lessons are, I think, very helpful for the general audience to know. Thank you for sharing that. So unfortunately, proton is not allowed in this trial, as currently proton therapy is not standard to treat GBM outside clinical trials. Although the BN-01 showed very promising finding, as presented by Dr. Mehta, I think even he would admit that a follow phase 3 study is necessary to verify the promising finding of that randomized phase 2 BN-001 study before considering proton therapy as standard of care. Furthermore, as we discussed, due to the longer time required to deliver TMPRT, as well as limited proton machine resources, I don't think it's a good technology utilization right now to test TMPRT with proton therapy. So it is not allowed, unfortunately, for CC017.
You've mentioned that you've been involved with some of the prior experience with temporally modulated pulse radiotherapy, particularly the phase 2 trial out of William Beaumont, where you did training, as I recall. There don't appear to be any worse side effects when using TMPRT. The data seems to suggest that there might be improved outcomes without worse side effects. That being said, for a patient out there who's considering enrolling on this trial, what potential risks do you want them to know about if they're going to sign up for CC017?
Although the phase 2 Beaumont study is very promising, it is still a single institutional study with relatively small number of patients. So therefore, really need a larger phase 3 to not only confirm the efficacy finding, but also to ensure it's safe. So to put my cautious hat on, I do worry that there is a possibility that TMPRT may be actually less effective or maybe even more toxic, even though all the preclinical data and clinical data does not seem to suggest such signal. But because of that caution, we also designed CC017 with 3 planned interim analysis that will look at overall survival at predefined time points. So basically, as 3 intervals, we will stop the study and essentially look at survival to make sure that the experimental arm with TMPRT does not cause worse overall outcome. And this is a safety net to make sure that we're not putting too many patients at too much risk should the TMPRT be worse. And this is actually another reason why we decided to focus this phase 3 study on the MGMT unmethylated glioblastoma, because we do not want to test this novel technique in the more favorable methylated group in this first phase 3 trial. We will be capturing grade 3 or more severe events from patients in both arms to make sure that we're not seeing any increased side effect profile from this TMPRT technique.
Given the promising preliminary data we have on temporary modulated pulse radiotherapy, we obviously want to do everything possible to help get the word out and make accrual to CC017 a success so that we can successfully test and hopefully answer this clinical question. You've already done webinars, Jay, and a lot of legwork to get the word out. What are the accrual goals for CC017? And for centers wanting to get involved and get this trial open, what resources would you recommend to help facilitate?
In designing this trial, we did multiple surveys across community centers, and we look at prior historical enrollment of similar population in prior NRG trials. So we estimated we will screen about 20 patients per month and enroll 12 patients per month. So we anticipate to complete this study in about 4 years. The activation of NRG CC017 is actually very similar to many other NRG trials, with one small difference. So this study will require IRA credentialing for TMPRT, especially if you want to use VMAT-based delivery to deliver TMPRT. And that credentialing process is very similar to how centers credential for MRT. You basically read the head and neck phantom and then send back the phantom with the radiation delivery record. WashU has recently just completed this process. It's actually fairly easy, and we anticipate to open the study in the next couple of weeks. Anytime we do something new and may feel scary, may feel complicated, but in reality, TMPRT is really quite simple. The CTSU website has all the study documents that you need to open the trial. There's a slide deck called the training slide that basically cover all the key information. We also recently did a webinar that cover all the key topics, and that recording is available in CTSU. The CTSU website also has PowerPoint slides on how to plan for TMPRT, neurocognitive function certification, how to do the frailty assessment. The CC017 study team and I'm always available to answer any questions. Just you can always reach us by email. We will also present this study at the upcoming NRG summer meeting in the next couple of days during the NCORP town hall and BRIN committee meetings. One other thing I just want to emphasize that's important about this trial, since the neurocognitive function is a primary endpoint, I would encourage all the participating sites to do their best to ensure the neurocognitive function testing completion is as compliant as possible. We have a great neuropsychiatry team led by Dr. Jeff Whiffle, so feel free to reach out to them if there's any questions. We'll be tracking neurocognitive function testing compliance, and the center will be judged by NCI based on this performance, since neurocognitive function is a primary endpoint. We will also meet sites that are underperforming to see if there are ways we can help them to improve. Neurocognitive function testing will be done 1 month after RT and every 2 months until month 9.
Dr. Huang, I want to thank you again for coming on the NRG Oncology podcast for this 2026 Glioblastoma Awareness Day to speak about your recently activated protocol NRG Oncology CC017 for centers out there who might see glioblastoma wanting to implement a pragmatic trial. As you've heard from Dr. Huang, this is something fairly easy to do as far as clinical trials are concerned.
Thank you, Stephen and Lauren, for having me. It's really my pleasure to chat with you and great catching up with you.
So next up on the NRG Oncology podcast, we will be shifting gears for a conversation on facilitating clinical trial accrual with a very well-known entity in breast cancer and the NRG Oncology circles. Our guest is Dr. James Abraham, who is the Chair of Hematology and Oncology at the Cleveland Clinic and a fellow member of the NRG Oncology Protocol Operations Management Committee.
Believe it or not, Dr. Abraham and I have more in common than you might think. Both of us grew up in what some would call a tropical paradise. Dr. Abraham is from Kerala, India, whereas I'm from Honolulu. Dr. Abraham and I were both inspired to go into oncology because of someone we knew with ovarian cancer. And interestingly, both of us grew up Catholic and were influenced by a Jesuit education. Dr. Abraham, how is it that guys like us ended up abandoning lives in a tropical paradise for places like Cleveland and Houston?
Thank you, Stephen, and thank you, Lauren, for having me on your really famous podcast. I'm really impressed with what you both are doing to bring awareness to clinical trials and clinical research. So, Stephen, thank you for doing that background research on me. I asked that question to myself multiple times, how I ended up in below freezing from a tropical paradise like Kerala, India.
Getting back to the focus of this podcast, we wanted to delve into the challenges and the solutions, hopefully, of cancer research at large institutions like the Cleveland Clinic. Some would say that many institutions have been in a state of crisis with cancer clinical research for years. Could you start off with describing the clinical research program at the Cleveland Clinic and what strategies are undertaken to avert maybe some of the chaos that is all too common in clinical research?
Thank you so much for that question. And of course, we work together as part of the Case Comprehensive Cancer Center. Our lab membership or labs accreditation or the NCI CTN trials is through the Case Comprehensive Cancer Center. Cleveland Clinic has fairly robust clinical trial. Again, Case Comprehensive Cancer Center is one of the highest labs accruing site in the country for the last many years. And then Cleveland Clinic University Hospital plays a crucial role in clinical trial accrual in NCI CTN trials. So the way we are dividing, and probably like any other major cancer centers in the country, we have number of industry-sponsored trials. We have NCI CTN trials through NRG, SWOG, ECOG, and some alliance trials too. And then we have IIT trials. As Lauren was alluding, clinical trial around the country is facing many headwinds from the funding, NIH funding, NCI support, and of course, overall, how the healthcare market is facing its own challenges. So it's all kind of coming together at the same time. So we try to make sure when we pick the portfolio of trials, we have a financially viable or fiscally responsible path forward. So, of course, industry trials support that. IITs probably neutral, and NCI, CTN trials, in general, we lose money. But all those three trials are extremely important to continue to focus on our mission of research. At main campus, we focus on some of the phase 1 or early phase industry-supported trials, IITs, and then we have 15 different sites in Ohio, and we have 3 different hospitals in Florida. When we go out of the main campus, we tend to do more phase 3 NCI CTN trials, or less complicated phase 3 industry-sponsored trials. It's a struggle, but we intentionally focus on the fiscal responsibility, which the time requires us to focus on that.
On that topic, you've had a lot of involvement with the National Cancer Institute and NRG Oncology over the years. A longstanding issue facing cancer centers, as you mentioned, is that the case reimbursement to institutions for enrolling patients on NCI-sponsored trials is truly a fraction of the actual cost of the institution. And even taking into account NCI grant funding through things like Cancer Center Support Grants or CCSGs and Lead Academic Participating Site or LAPS grants, it's pretty clear that they don't really come close to covering the cost of NCI-sponsored trials. Can you tell us about the NRG Oncology program in particular at the Cleveland Clinic, and how has Cleveland Clinic balanced NRG Oncology trials with competing industry-sponsored trials that maybe make more financial sense for the institution? What keeps the investment, and how do you balance the investment going with NRG?
One, I really owe to NRG or NSABP for my career. I know Stephen asked me how you ended up in a beautiful Cleveland. So from NCI, I went to West Virginia. When I was in West Virginia University, I started attending the NSABP meeting and being part of the NSABP and NSABP trials. And that really helped in launching my career. And of course, then later, in 2014, when the NRG was formed, and I was fortunate to be the vice chair for research strategy. I've been working with the NRG and NSABP Breast Cancer Working Committee. So why do I say that? I'm not saying that to show what I'm doing. If you talk to hundreds of investigators around the country, large number of them will say their career in clinical research was supported and shaped by cooperative group. Now, as the department chair, I clearly understand the value of NCI CTN mechanism or NRG. So in addition to the financial things you mentioned and we talked before, I clearly understand the value of how NCI CTN trials shape and support our young investigators. Second, NRG or NCI CTN trials, those are practice-changing trials. So I think it's important for the cancer center leadership to continue to understand all the different aspects of the value the cooperative group trials are bringing to the institution. And I'm not saying it's an easy task. We ask each program balance their portfolio so that they can have a fair number of both NRG or NCI CTN trials and industry trials, and in addition to IIT. So each program that we want to have a balanced portfolio so that they're not losing money and they can still continue to support the NCI-CTN trials through the LAPS mechanism.
Moving on to a different topic, in addition to the financials, one of the big pain points involved with clinical research across institutions throughout the United States are the increasing administrative and bureaucratic challenges that face cancer researchers. One of the big challenges of large institutions is the tendency of bureaucracy and administrative burden to increase in a way that is reducing the efficiency of activating and conducting clinical trials. I often hear from industry sponsors, for example, that it takes a year or longer to open their trials, their industry-sponsored trials, or ISTs as you call them, here in the United States than it does to get the same trial open in Europe or Asia. What have been the most effective strategies you've seen in your career to reduce trial complexity and administrative burden at a big place like the Cleveland Clinic to mitigate these challenges we are seeing that tend to just make trials get bigger and more complex?
We just finished the Destiny 05 trial, or NSABP-B60, which is a global trial with more than 400 sites in 30 different countries, enrolling 1,865 patients. So that trial closed ahead of its accrual time. Globally, we were able to accrue patients almost 3 months ahead of time. As you just mentioned, time is money. Time is getting the most effective treatment to the clinic in a timely manner. That kind of illustrates some of the international sites how really streamline the process. So many sites in the US, especially large academic centers like ours, it's a work in progress. There are many things we are trying to do. We are trying to streamline the budgeting process. We are really trying to streamline the contracting process. We are trying to look at even the IRB process. And then, of course, the next really important thing is how do we screen and accrue patients? So it's a work in progress. And hopefully, with the introduction of newer technologies like AI.
I wanted to return to where we mentioned our work on the NRG Oncology Protocol Operations Management Committee. You, Lauren, and myself are all part of this committee. And for those of you unfamiliar with the Protocol Operations Management Committee, or POM, as it's abbreviated, we are tasked with finding ways, like this podcast, to promote and increase accrual to NRG trials. There are lots of ways that institutions can promote clinical trial accrual. At some institutions, physicians are directly incentivized to enroll patients by linking their enrollment to things like salary and bonuses. At other institutions, perhaps faculty promotion is tied to clinical trial enrollment. How do you incentivize your faculty to participate in clinical trials? Obviously, Case and Cleveland Clinic have very high numbers of enrollments, as you spoke about earlier in this podcast. What is your take on the best practices for incentivizing trial enrollments, whether it be financially or otherwise, and how are you doing it?
Stephen, that's a really important question. As we talked before, in addition to getting the treatment, getting the trial to the patient, it really fosters career development of our doctors. In Cleveland Clinic, we have 4 different tracks. We have master clinicians who are the most important part of our clinic and our practice. They mostly see patients and they support our practice across our network. And their expectation is providing the best care and enrolling patients in trial. Then we have clinical scholar track. That's the second track. That large number of main campus doctors are clinical scholar. For them, there's a high expectation of clinical trial participation. So means they are being institutional PI, national PI, or national study chair, and most importantly, clinical trial accrual. So the 2 tracks are clinician educator and then clinician scientist. Clinician educators are like the program directors, clinician scientists, those people in the lab, mostly NIH funded. So coming back to this clinician scholar and master clinicians who are the larger pool of our colleagues, there is an expectation that they need to aim to meet that goal of enrollment on clinical trials for these tracks.
Let me ask just real quickly, do you have specific benchmarks for enrollments for these particular tracks, for these clinician scholars or clinical tract faculty who are the boots on the ground?
So what we say is minimum 6 patients per year. So it's not that high. And as I said, we have about 75 doctors at the main campus and 40 in our region in Ohio. Majority of them are clinical scholar or master clinician, and we expect about 6 patients per year. So it's not a huge target, but that's a target we set. And then I know you asked, there's any financial incentive. Actually, Cleveland Clinic and probably many centers, we are a salaried institution. We are not RVU based, and there's no incentive tied to accrual, but we have goals which we want to achieve. And of course, when we talk about merit increase or meeting the goals for the year in our annual performance review, which, and as the department chair, and I meet with all my doctors once a year, and this is something we talk about. One of their publications, clinical trial engagement, clinical trial accrual.
So on one hand, we've spoken about the incentives, the ways to promote good behavior in terms of clinical trial participation or research with the faculty. But for faculty who might not be meeting those expectations, when we talk about carrots and sticks, carrots can be a good motivator, but on the flip side of the coin, how do you disincentivize people from disengaging in clinical research and being unsupportive towards clinical trials? What sort of sticks do you have that might motivate faculty who are not meeting expectations in their support of cancer clinical trial enrollments? For example, let's say you have a faculty member who for multiple years is not enrolling any patients on a trial, whereas their colleagues of the same rank are enrolling numerous patients seeing the same disease site.
I clearly view our doctors, they bring different values to the team. Some people are stronger in teaching, some people are stronger in writing and publication, some people are really outstanding world-class doctors, and some people are really driven by clinical trials and clinical research and clinical trial accrual. So, of course, I look at each person, who they are. But as you mentioned, somebody is a clinical scholar, and the expectation is to focus on clinical trials and enroll patients on trial. We have this conversation. Do you want to change the track? And do you want to be more of a master clinician? Then there's less pressure of being a clinical scholar and meeting some of these research goals. That's the stick, or that's the conversation. Changing their priorities mainly to focus on, again, that's an important mission of seeing more patients than focusing on clinical trials and clinical research.
Well, Dr. Abraham, I want to thank you again for taking the time to join us on the NRG Oncology podcast and your words of wisdom from your long career as a leader in clinical trials.
Thank you, Stephen.
Thanks for tuning in today to the NRG Oncology podcast, kicking off this July 2026 semi-annual meeting in Denver. With us today, we had Dr. Jiayi Huang speaking about the recently activated CC017 trial of temporally modulated pulse radiotherapy for glioblastoma, and Dr. James Abraham, the chair of hematology and oncology at the Cleveland Clinic, speaking about strategies to promote accrual. Lauren and I look forward to seeing you in person here in Denver. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks everyone for tuning in, and happy clinical trials.